Okay, hello everyone. Good afternoon. Welcome to our session, Targeting CKD and CKM Syndrome, Exploring the Role of GLP-1 Receptor Agonists. This session is supported by an educational grant by Novo Nordisk. And my name is Andrew Bzowicki. I have the privilege of moderating today's symposium. But at this point, I'm extremely excited to introduce the stars of today's show. These are our highly esteemed speakers. So Dr. Jennifer Trujillo is a professor and the Associate Dean for Education at the University of Colorado School of Pharmacy. She's a clinical pharmacist and a certified diabetes care and education specialist at the University of Colorado Diabetes and Endocrinology Clinic. She's an associate editor of Diabetes Spectrum and an editorial board member of the journal Pharmacotherapy. Her research interests are in the areas of diabetes education, support in medication optimization, and the scholarship of teaching and learning. And then also we have Dr. Suzanne Nicholas. She's the professor of medicine and hypertension specialist at the David Geffen School of Medicine at the University of California, Los Angeles. She chairs the UCLA Division of Nephrology and the Racial and Health Equity Committee. And we'll please welcome, or these are the disclosures on this slide here. And I'd like to welcome Dr. Nicholas for the first portion of the program.
Yeah. Okay. Afternoon, everyone. It's really such a pleasure for me to speak to you today on this amazing and really timely topic. And so the learning objectives for this session are to recognize the interconnectedness between chronic kidney disease and cardiovascular kidney metabolic syndrome, to explain the emerging role of GLP-1 receptor agonists in treating patients with chronic kidney disease, and to examine the risks and benefits of GLP-1 receptor agonists for patients with chronic kidney disease. So we'll start with a case vignette on integrating GLP-1 RAs into the CKD treatment paradigm. So this is our case introduction. This is a history of present illness. We have a 54-year-old man establishing care with a new primary care provider after relocating for a new job. He needs refills on several medications. He was diagnosed with type 2 diabetes 4 years ago based on an A1C of 8.9%. And at diagnosis, he was encouraged to cut back on sweets and sugary drinks, to lose weight via calorie restriction, and to increase exercise. Metformin at 500 milligrams twice a day was prescribed, with a titration schedule increasing twice daily. He has type 2 diabetes in his past medical history, hypercholesterolemia, hypertension, obesity, chronic kidney disease, depression, and a history of pancreatitis. Was diagnosed in 2014. His family history is significant for mother and sister with type 2 diabetes. His father passed away from cardiovascular disease at age 26. And his social history is significant. Never had a history of smoking, no alcohol use since 2014, commercial insurance. He reports financial, housing, transportation stability, as well as food security. In terms of his diet, he switched sodas to diet soda. He decreased fast food at lunchtime. He eats dinners at home, and he identifies portion sizes and pre-made foods as challenges. Regarding physical activity, he walks outside about 30 minutes, 1 to 2 times per week. He reports limited gym options in his neighborhood, and cold weather is a bit of a deterrent. In terms of medication taking behaviors, he reports missing 5 doses of metformin in the last week and is out of amlodipine as well as atorvastatin. There are no missed doses of other medications, however, but he does report diarrhea with metformin. These are his medications as well as his labs and vital signs. So he's taking atorvastatin at 80 milligrams once a day, lisinopril 40 milligrams once a day, amlodipine 5 milligrams once per day, multivitamin gummies at 2 PO daily, famotidine 20 milligrams as needed for heartburn, paroxetine 20 milligrams once a day, and metformin, he's now taking 1,000 milligrams twice daily. His vital signs are, as you see, blood pressure of 137/84. His heart rate is at 70. He's 6 feet 1 inch tall. He weighs 234 pounds, and his BMI is at 30.9. Regarding his labs, as you can see here, they're labs from 8 months ago and labs today at the initial clinic visit, which shows an A1C that was previously 8.9 is now 8.1. His serum creatinine was 1.6, is now 1.7. His eGFR was 56, it's now 52. His TSH was 2.8, it's now at 2.9. Cholesterol is 130, is now up at 207. His HDL was 38 and is now at 39. Triglycerides were 130 and now at 188. His LDL is 70 and has increased to 130, and his UACR was 520 and is now at 318. So keep these in mind because you will be quizzed on this in a bit. So now I'd like to talk to you about putting the K in CKM and the role of CKD in this updated paradigm. And I really want to start by saying that, there's so many things that I love about the field of nephrology. But one of them really is the fact that we continue to evolve over time based on the knowledge that we gain. And it's all about really improving the care for our patients. And I think CKM is one of those prime examples that demonstrates this evolution. Okay, so the learning objectives, where are we? It's going backwards. All right, let's see, we got this. All right, so for this talk, I would like to begin with a review of the terminology, epidemiology, and staging of chronic kidney disease and cardiovascular kidney metabolic syndrome. And then we'll discuss the interconnectedness between CKD and CKM syndrome. And finally, we'll discuss why putting the K in CKM is beneficial. So let's begin with talking about the terminology. And certainly, this audience is very familiar with the definition of chronic kidney disease, where the focus is primarily on the kidney. And we know that the definition and classification with CKD was introduced in 2002 by the National Kidney Foundation, where it was defined as an abnormality in kidney structure or function that lasted for at least 3 months. And we know that most individuals don't really experience any symptoms of chronic kidney disease until the more advanced stages. And as such, we really need to screen, not everyone, but certainly those who are at risk for CKD with a morning urine sample for albumin to creatinine ratio and or a blood test for estimated glomerular filtration rate or eGFR. So an individual who's diagnosed with chronic kidney disease will have a UACR of greater than 30 milligrams per gram and an eGFR lower than 60 milliliters per minute per 1.73 meters squared. And then came the term cardiorenal syndrome, or CRS. And this was introduced in 2004 by the NHLBI working group, where they recognized the focus really was on this bidirectional interplay regarding dysfunction between the heart and the kidney, and they provided, subtypes, about 5 subtypes for this disorder. And then in 2009, the term cardiorenal metabolic syndrome was introduced again as a result of a consensus meeting group where they recognized the pathophysiologic relationships between cardiovascular disease, kidney disease, and metabolic disorders such as diabetes. And these 3 components of cardiorenal metabolic syndrome have overlapping factors. And the goal really was to emphasize the need to have a holistic approach to managing these disorders. So fast forward to 2023 came the official term cardiovascular kidney metabolic by the American Heart Association, which at this time then recognized that there was a much more robust understanding of the interconnectedness of these three components. And they also recognized that it was much more complex. And it was really a systemic disorder based on a cluster of interrelated pathophysiologic diseases, including chronic kidney disease, cardiovascular system, and metabolic risk factors such as diabetes, and especially obesity. And we'll talk a little bit more about that in a second. All of these leading to a multi-organ dysfunction. And in addition, within this CKM syndrome, it really included individuals who were not only at risk for cardiovascular disease, but also those with existing cardiovascular disease, thus increasing their likelihood of developing CKM syndrome. And unfortunately, this syndrome is very much associated with adverse clinical outcomes. And many of these clinical outcomes can be influenced by unfavorable conditions resulting from things such as policies, economics, and the environment, all sort of placed under the umbrella of social determinants of health. So let's look at this interrelatedness between metabolic factors of and cardiovascular disease and CKD as part of CKM. And it begins with excess or dysfunctional adipose tissue leading to chronic inflammatory state that results in dyslipidemia, metabolic syndrome, and hypertension, insulin resistance, and type 2 diabetes. And as a result of this chronic inflammatory state, there's also an impact on cardiovascular disease marked by myocardial remodeling and cardiac fibrosis. And in addition, in the kidneys, you can develop chronic kidney disease marked by glomerulosclerosis and tubular interstitial fibrosis. Turns out that there's an estimated more than 1 billion with a B individuals worldwide who are affected with some level or degree of CKM. And 1 in 3 adults globally may have at least one component of CKM. The prevalence of CKM is also rising, and this increase in the prevalence seems to be driven by our obesity epidemic, as well as our aging population and urbanization and a more sedentary lifestyle. And as such, now a number of organizations are providing new guidelines shifting towards a more CKM framework, and several of those organizations are listed here. So it stands to reason that it's a good opportunity for us to really understand some of the pathophysiology around CKM and to actually get on board. So what are some of the risk factors for CKD and CKM? It turns out that many risk factors actually overlap, and some of them are listed here, including diabetes, type 2 diabetes, hypertension, obesity, smoking, dyslipidemia, a family history of kidney or heart disease, age greater than 60 years old, ethnic minority individuals, including African Americans, American Indians, South Asian individuals, and individuals with low socioeconomic status. Now, looking at the pathophysiology of the CKM syndrome, let's start with the adipose tissue. Under normal physiologic conditions, adipose tissue are fat cells, particularly white adipose tissue that is found around visceral organs and subcutaneous fat, become dysfunctional under pathophysiologic conditions. Physiologically, adipose cells will produce adiponectin, and these cells play a very important role in terms of regulating insulin sensitivity, glucose, and lipid metabolism. But as a result of many of these risk factors that I just mentioned to you, the fat cells and the adipose tissue can become quite dysfunctional and produce a number of pro-inflammatory cytokines, such as IL-6, TNF-alpha, and IL-1 beta. And this now causes dysfunction of adipose tissue. And again, as I mentioned, particularly white adipose tissue in visceral fat and subcutaneous fat, as well as in bone marrow. And as a result of this, you then have this dysfunction across a number of organs, including the brain, in macrophages, in the heart, in skeletal muscle, in the vasculature, the pancreas, the liver, as well as the kidneys. There are also a number of risk-enhancing factors for the CKM syndrome that include a family history of diabetes or kidney failure, having a chronically high sensitivity CRP, at least 2.0 milligrams per liter or greater, in conditions such as lupus or HIV/AIDS. And also for high-risk demographic groups, some of which I mentioned previously, South Asians and individuals of low socioeconomic status, belonging to these groups can accelerate the progression of CKM to more advanced stages. Mental health disorders such as depression and anxiety have also been linked to some of the CKM components. And sleep disorders such as sleep apnea, insomnia, and restless leg syndrome also have been linked. Adverse social determinants of health, including economic instability, low education, poor access to health care, or under-resourced neighborhoods and low social community contexts, may also put an individual at risk for faster progression of CKM syndrome components, as well as lower ability to manage treatment to maintain these CKM syndrome components. And a little bit more about the social determinants of health. This can occur at a number of different levels, and even at the individual level may include factors such as the microbiome or genetic and epigenetic factors. But in addition, behavioral factors may come into play, relationship factors, community and societal factors that may all lead to an increase in the likelihood of progression to more severe stages of CKM. So what about the staging of CKM syndrome? This is a great slide. It puts everything on one page that you can see. For stage 0, that describes an individual who really has no risk factors for CKM. At stage 1, the individual now starts to develop excess and dysfunctional adipose tissue, again, in response to many of the factors that we talked about previously. At stage 2, this is where there are metabolic factors and chronic kidney disease that define stage 2 CKM. And as the individual progresses across the stages, at stage 3, there's subclinical cardiovascular disease in the CKM syndrome. But at stage 4, which is the most advanced stage, there's now evidence of clinical cardiovascular disease marked by factors such as heart failure, stroke, peripheral arterial disease, atrial fibrillation, as well as coronary heart disease. So let's talk about putting the K in CKM. And I smile because you know what the K stands for, right? It's the kidney, right? The kidney disease improving global outcome classification for chronic kidney disease, as well as for risk assessment for chronic kidney disease progression. And we're very familiar with this KDIGO heat map that allows us to stage chronic kidney disease across the 5 stages, G1 through G5, based on the eGFR, as going to as low as less than 15 milliliters per minute, 1.73 meters squared, in addition to albuminuria levels at categories A1, A2, and A3, denoted by UACR measurements lower than 30 to greater than 300 milligrams per gram. And as an individual may progress over these, the color-coded heat map, someone within the green zone may have low risk for CKD progression or for cardiovascular risk. But as they progress to the yellow zone, they may now have moderate risk. And then to the orange zone, they may have high risk. But to the red zone, that's where the individual will really be at very high risk for CKD progression and risk for progression of CKD as well as cardiovascular. The great thing about this KDIGO heat map is that it also allows us to have in one page or one picture, a great assessment of the frequency of how often a patient needs to be seen, either for screening for those at low risk, or to be seen in the clinic, as well as to initiate treatment and for referral for nephrology care. So one of the things that I've been working on is trying to align CKD using the heat map and CKM staging, right? To try to make it a little bit simpler. So walk through this with me. So let's see, for someone at stage 1 CKM, where there's low metabolic risk, there's excess dysfunctional adiposity, this individual would be at low to moderate risk, and their eGFR may be greater than 60, and they would be in the A1 UACR category. For someone at stage 2, where there's now metabolic risk, they may have early organ dysfunction, and this would place them at more moderate to high risk, where their eGFR is reduced anywhere between 45 to maybe as high as 89, and now they're in a higher albuminuria category at A2. And as they progress to stage 3 CKM, they now have developed moderate to severe CKD and cardiovascular risk, and they're at really now high and very high risk stage, and the eGFR is lower, between 30 and 44. And again, they're also at the higher UACR category of A3. And then, of course, as you can imagine, the more advanced stage, they're at severe risk for CKD progression, really at the highest level here, and the eGFR may be lower than 30. So putting it all together, this is what it would look like. CKM1 in the green, CKM2 in the yellow, CKM3 in the orange, and there's some overlap for CKM3, and then CKM4 in the red, very high risk. So take a look at this. I've been working on this. Let me know if you think it fits well with what you believe it should look like. But I think it's a great opportunity to have everything in one place. So how about the frequency of monitoring for CKM syndrome? Well, for CKM stage 0, where there's no CKM risk factors, you really want to start screening adults every 3 to 5 years with the goal of assessing items like blood pressure, triglycerides, HDL, their blood glucose. And the goal really is to prevent unhealthy weight gain and to prevent hypertension and other disorders. At CKM stage 1, where you already have excess dysfunctional adiposity, you want to screen every 2 to 3 years to really support healthy eating, exercise, and lifestyle. But as individual progresses to CKM stage 2, where there's metabolic risk factors, you want to screen at least more than once a year, and of course more frequently for stage 3 and stage 4. So how can we assess risk for cardiovascular disease? I'm sure that many of you are familiar with the ASCVD, as well as the PREVENT calculator, which you can find online. But what I'd like to do is to describe the characteristics of each of these and to show you that we really urge you to use the PREVENT calculator over the ASCVD calculator. Both of these really estimate risk for cardiovascular disease, but importantly, they serve different purposes and different populations. And what you see here is the ASCVD risk calculator has been much more long-standing. It's a guideline integrated tool compared to the PREVENT calculator, which actually came about around the same time as CKM syndrome was defined. It's a newer, more modernized risk engine, and the ASCVD can estimate 10-year atherosclerotic cardiovascular risk, but the PREVENT can actually estimate not only 10-year, but also lifetime cardiovascular risk. And I'll show you an example of that. The ASCVD risk calculator is really limited to clinical biomarkers, whereas the PREVENT calculator really gets us thinking more about CKM because it adds social, behavioral, and expanded clinical factors. ASCVD tends to focus narrowly on only ASCVD events, whereas the PREVENT calculator has much broader risk spectrum and more dynamic potential. And then finally, the ASCVD calculator seems to be less customizable, whereas the PREVENT calculator is more inclusive and equity focused. And this shows you the factors that are incorporated into the ASCVD calculator and the PREVENT calculator. And you can understand why I'm encouraging you to use the PREVENT calculator, because it includes chronic kidney disease. In addition to, of course, social determinants of health, family history of cardiovascular disease, and BMI. So this is what, if you went on, I don't have any stock in Google, but if you Google the PREVENT calculator, this is what you'll see, and you'll be able to punch in the values for each of these parameters for your patient. But interestingly, it also provides you opportunity to include the UACR, the A1C, and individual zip code. So when would you use the PREVENT calculator as opposed to ASCVD? If you want to estimate total cardiovascular disease events, if you're considering multiple outcomes, including heart failure and atrial fibrillation, if you would like to calculate not only 10-year, but 1-year, 5-year, and 30-year risk, or even lifetime risk for cardiovascular disease, if you'd like to include broader risk factors like CKD, heart rate, and frailty index, and you would like to use the PREVENT calculator in older adults or those with multiple chronic conditions. And also when you want to estimate total cardiovascular burden, not just the initial risk, and for shared decision-making regarding the comprehensive cardiovascular risk, as well as in primary care settings where a much broader picture of risk is warranted. When it comes to managing CKM, and I would say CKD, lifestyle is really the basis and the foundation as the initial therapy, focusing on nutrition, physical activity, sleep, alcohol, smoking, and mental health. When it comes to managing the earlier stages of CKM, we want to really focus on, because I need my glasses for, promoting cardiovascular health, as well as systematic screening for social determinants of health. And at stage 1 CKM, where there's excess dysfunctional adiposity, you really want to focus on weight loss and to use metformin where it's necessary. But in stages 2 and 3, you really want to incorporate more interdisciplinary care, focusing on managing hypertriglyceridemia, hypertension, and chronic kidney disease, as well as diabetes. And of course, consideration for metformin, again, as co-utilization. And for CKM3, where there's subclinical cardiovascular disease in CKM, want to focus on managing subclinical atherosclerosis, as well as heart failure. In the advanced stage of CKM, really the focus includes all of what we've just talked about, but in addition, managing heart failure with the use of guideline-directed medical therapies for all patients, and as well as atherosclerotic cardiovascular risk, managing the dysfunctional obesity, as well as what we've talked about for CKM 1 and 2, managing hypertriglyceridemia, hypertension, et cetera. So as you can see, if we can manage these, there will be multiple benefits for managing and treating CKM syndrome, including reducing cardiovascular risk, reducing kidney risk, multiple metabolic benefits, as well as a number of other benefits, several of which are listed here. So, I want to get on to our first question, which is, try to remember now, according to the KDIGO CKD heat map, which risk categories are patient in? Remember, the GFR at the time of the clinic visit was 52, and the UACR was 318. Okay, we already have several responses. We'll wait for a few more. We're up to 40. Great. Many more of you in this room, so go ahead and vote. eGFR 52, UACR 319. I feel like we need a little bit of music. Okay. Couple more. All right, so what's the right answer? So moderately increased risk in the yellow, right? 54% voted there. Well, let's take another look. The eGFR was 52, and their UACR was over 300. So that puts them right at very high risk. How interesting. I think that tells us a lot right here. And it tells us the value of a number of things. One, making sure the patient has not only the eGFR, but also the UACR. But if you can keep a copy of the KDIGO heat map with you in clinic, as well as when the patient walks in to the office, they can visually see where they are. And the intention then in treatment is actually hopefully to move them upwards or at least stabilize them. So I think this is very, very valuable. Okay, another question. What stage of CKM syndrome does our patient have? There are no clues for this one. So remember, cardiovascular, kidney, and metabolic. And there are a number of other clues within the history. Okay. Stage 3. How about that? Wonderful. I feel vindicated. They actually listen. Wonderful. Congratulations. You may have dessert. So if you were to guess, and this one is a little bit, I guess, a little more difficult, what is our patient's estimated 10-year risk of CVD using the PREVENT calculator? And I get it, I haven't given you the calculator, but I want you to think about what it might be, let's say without the UACR and some of the other factors versus with. Just take a guess. Everyone's taking pictures so they can go back and review. All right, 25%. How did they figure that? That's pretty good. I'm so proud of you. That's wonderful. So when we went online and we actually punched the numbers in, it turned out to be 25.6%. So that's amazing. And when you add the UACR and some of these other measurements, look at what happens. You actually, the risk is at 19 point, if you do not include the UACR and the A1C, you really miss a certain significant percentage of risk, right? And that can actually change the discussion and your management. So we've given you now a number of very important tools of how you can manage individuals with CKM syndrome. So I will end by just this one slide that describes the approach to CKM syndrome, indicating that it is indeed multidisciplinary, but very important, also includes kidney, the K, education, screening, diagnosis, and management. So with that, thank you, and I will bring my colleague up. No. But this, I will leave this.
Thank you, Dr. Nicholas, for setting the stage so nicely for me. I'm going to shift gears just a little bit and have a deeper focus on CKD and the treatment of type 2 diabetes in patients that also have CKD, with a focus on where the GLP-1 receptor agonists fit in. I'll use this. Okay, so when we're looking specifically at the treatment of type 2 diabetes in the setting of CKD, of course, I work in a diabetes clinic, so I have a glucose-centric mind occasionally, but we know now that we're certainly more concerned at looking at patients from a more holistic perspective, with treatment goals that really include a reduction in the risk of CKD progression, but also a reduction in cardiovascular events and other complications. Of course, we partially do that by a reduction in glucose control, but we also want to make sure we're targeting other contributing factors, including blood pressure, lipids, weight, smoking, et cetera. Now we have the opportunity to use preferred agents that not only lower those surrogate markers, but also have organ protective effects in and of themselves. Of course, including our tried and true ACE inhibitors and ARBs, but also looking at our anti-hyperglycemic agents, the SGLT2 inhibitors, and the GLP-1 receptor agonists. We need to do that through shared decision-making and in a way that we can minimize the side effects and minimize the treatment burden. So going back and looking a little bit about what some of our key guideline recommendations say, let's start with the KDIGO ADA consensus statement that was published in 2022. If you look at the green boxes, those are the ones that are focused on the treatment of type 2 diabetes specifically. And you can see that back in 2022, these guidelines recommended SGLT2 inhibitors as the first-line therapy for glucose control, along with metformin, as long as the eGFR was over 30. You don't see the GLP-1 receptor agonists in these guidelines pop up until you go to the next stage, where it says you could consider the GLP-1 RAs if you needed additional glucose lowering. I think the next time these guidelines are published, you'll see a change in that hierarchy. You do see that change if you look at the 2025 ADA guidelines. These are the standards of care produced by the American Diabetes Association. They are updated annually, and there was a significant change this year based on new evidence. If you haven't looked at the ADA guidelines for a while, you can see that it's not a glucose-centric approach anymore. It really is a holistic approach looking at a lot of the key features that we've been talking about related to CKM. So if you look on the left side of the algorithm, you're seeing the major comorbidities, including ASCVD or high risk for ASCVD, heart failure in the middle, and then CKD right next to that. These guidelines really identify that if a patient has any of those comorbidities, that you need to be using medications that have that organ protective benefit above and beyond their ability to lower glucose. Then, if you don't have any of those comorbidities, some other things to think about that you see on the right side of the guidelines include the ability for them to lower glucose and the ability of agents or the impact of certain agents on weight. So we really want to keep all of those in mind. Of course, on the very left, for those that have ASCVD or high risk for ASCVD, the recommendation is to use either an SGLT2 inhibitor or a GLP-1 RA that has evidence supporting a reduction in major adverse cardiovascular events. If you have someone who has a comorbid condition of heart failure, then you'd want to use an SGLT2 inhibitor because that's where the strength of the evidence lies. Let's look a little bit closer, though, in the middle at the column related specifically to CKD. Here is where we saw an update in the 2025 guidelines, where previously there was a preference to use SGLT2 inhibitors because stronger evidence existed for that class of medications. But now the update for this year includes an or, so an SGLT2 inhibitor or a GLP-1 receptor agonist that has evidence in people with type 2 diabetes and CKD. I think it's important to note that the ADA really recognizes this idea of treating all of the comorbidities in this kind of CKM picture. And so they highlight that this is something that you would want to do irrespective of A1C. Meaning, even if someone's A1C is below target, you would still want to recommend starting an SGLT2 inhibitor or a GLP-1 for those added benefits above and beyond glucose lowering. I think it's important to mention the last two bullets as well. One is if you do need a glucose lowering, it's important to remember that once your eGFR falls below 45, the SGLT2 inhibitors start to lose their glucose lowering effect. So that might be a reason to consider one category over another. The GLP-1 receptor agonists are preferred when the eGFR starts to drop in terms of glucose lowering because they can be used safely, they still maintain their efficacy while also having a low hypoglycemia risk, and they still have that cardiovascular benefit. So let's dive into the data and the evidence that supports those guideline recommendations. And I'm going to just take a quick step back with the cardiovascular outcome trials, and I'm going to start with the SGLT2 inhibitors just to lay that foundation. These were published about a decade ago, so this is nothing new, but the 3 cardiovascular outcome trials for EMPA, CANA, and dapagliflozin are here in this table. They all evaluated people with type 2 diabetes with either pre-existing cardiovascular disease or high risk for cardiovascular disease. These were folks that most of the patients were on metformin. It varied in terms of that prior cardiovascular disease history, but all of them were positive results. So this was our first glimpse into having specific medications that could lower cardiovascular risk above and beyond their glucose lowering potential. What was really interesting with these studies is that we also saw a reduction in worsening nephropathy as a secondary endpoint across the board. And that's what led to additional studies that were done that really focused specifically on kidney outcomes. So we've got 3 dedicated kidney outcome trials, the Credence, DAPA-CKD, and EMPA-CKD, looking specifically at patients with different levels of CKD with diabetes or without diabetes. So most of these patients were on ACE inhibitors or ARBs as the backbone of CKD therapy, and their primary outcome was end-stage kidney disease, either an increase in creatinine or a reduction in eGFR at different levels, or cardiovascular death. Importantly, across the board, we saw significant results with those primary outcomes. So significant reductions in CKD outcomes in this patient population when you add an SGLT2 inhibitor to baseline ACE inhibitor or ARB therapy. If you think about the studies and where they fall in terms of the KDIGO heat map and the patient populations, you can see that the studies really demonstrate that SGLT2 inhibitors can really play a key role in preventing the progression of CKD in a variety of different levels, particularly in those orange levels and those red for the high or very high risk patients. So where do the GLP-1 receptor agonists line up compared to the SGLT2 inhibitors? So these are the cardiovascular outcome trials of the GLP-1 receptor agonists. These are the positive trials. So there were some other medications like exenatide that did not show benefit. But if we look just at the first 3 columns, leader, sustain, rewind, these were really the classic cardiovascular outcome trials for the GLP-1 receptor agonists. They looked at patients with type 2 diabetes, again, with either pre-existing cardiovascular disease or high risk, and they showed beneficial effects for these 3 medications, so lowering the cardiovascular events. But similarly to what we saw with the SGLT2 inhibitors, we also saw that secondary outcome that was positive. So we saw a reduction in kidney-related secondary endpoints for all 3 of those trials. The last 2 studies, the SELECT and the SOUL trials, are a little bit more recent, but also add a really interesting component to this discussion. The SELECT trial looked at semaglutide, the dose used specifically for weight loss, and it looked at the 3-point MACE as the primary outcome, but in a different population. So this was in the overweight, obese population without type 2 diabetes. And they found a reduction in cardiovascular events in people that were taking semaglutide for overweight or obesity. What's really interesting for this conversation and this meeting is that even in that patient population without diabetes, they saw positive results in the secondary outcome of worsening nephropathy. So I think that's really interesting, and we're going to see additional studies coming out looking into that population. And then lastly, I just wanted to mention the oral semaglutide trial, SOUL, just got published about 2 weeks ago that also showed positive results from a cardiovascular perspective. So those secondary endpoint results really then led now to one trial that we have that is a kidney-specific outcome trial looking at a GLP-1 receptor agonist, and that's the FLOW trial that looked at subcutaneous semaglutide. So the FLOW trial looked at patients with type 2 diabetes and varying degrees of chronic kidney disease, randomized patients to semaglutide, titrating the dose up to 1 milligram per week versus placebo. This was a fairly high-risk patient population. The vast majority of people were overweight or obese. About 50% had cardiovascular disease. About 68% were considered very high risk from a CKD perspective. Interestingly, they did allow for use of SGLT2 inhibitors and finerenone at baseline, and they ended up with about 15% of their patient population that were on an SGLT2 inhibitor. And the results were positive. We saw a reduction in the risk of major kidney disease-related events in the patients taking semaglutide compared to placebo, and also significant results for a variety of other outcomes as well, including persistent reduction in eGFR, cardiovascular-related death, and death from any cause. If you line up the results of the FLOW trial compared to the kidney-specific outcome trials for the SGLT2 inhibitors, I view them to be reasonably comparable. The patient populations that they were looking at were reasonably similar. The primary outcomes that they were looking at were similar, and the results, I think, were reasonably comparable. So you see a 24% relative risk reduction with semaglutide in the FLOW trial compared to 23 to 39% risk reduction with the SGLT2 inhibitor trials. And then looking at the specific patient population for the FLOW trial, you can see that they were looking at similar boxes on the heat map compared to the SGLT2 inhibitors, so getting at that kind of high to very high risk patient population. So I know there's a lot of GLP-1 receptor agonists on the market, and we're getting more and more data in these different disease states as the days and years go by. So I just wanted to provide a quick reminder of what we're looking at today. All of the agents that we have for the GLP-1s are on the left. I wanted to highlight tirzepatide at the bottom, which is a dual agonist, GLP-1 and GIP. All of these agents are approved for type 2 diabetes, but many of them have additional FDA indications based on the evidence that I just presented. So liraglutide daily, semaglutide weekly, and tirzepatide weekly are all approved under different brand names, and some of them with different dosing requirements for overweight and obesity. The three agents that I mentioned, liraglutide, dulaglutide, and semaglutide, are also approved for reduction of major adverse cardiovascular events in people with type 2 diabetes and cardiovascular disease. We also, because of the SELECT trial that I mentioned, the weight loss version of weekly semaglutide is also approved for the reduction of cardiovascular events in that patient population. And then based on the FLOW trial, now we have a new indication for the diabetes version of the weekly semaglutide, which is now also FDA approved for the reduction of CKD progression in that patient population. So if we're thinking about the potential mechanism for GLP-1 receptor agonists in CKD protection, it seems to be likely a combination of both direct and indirect effects. So we know that the GLP-1 RAs, just by lowering weight, by lowering glucose, by lowering blood pressure, that may be explaining quite a bit of the CKD protection benefit. But there are also some hypothesized direct effects, which were mentioned a little bit earlier in terms of the pathophysiology of CKM, including effects on inflammation, effects on oxidative stress. What I'm always thinking about is how whether or not medications are going to have added benefit when used together. So I think about, how does the mechanism for CKD with GLP-1 RAs compared to SGLT2 inhibitors? I think both of them are probably a combination of direct and indirect effects, but I do think the impact that they have regarding those indirect effects are different, and I think the direct effects are probably different as well, with the SGLT2 inhibitors focusing a lot on diuresis, on reduced intraglomerular pressure, whereas the GLP-1 RAs are potentially more focused on a reduction in inflammation and reduction in oxidative stress. I think this brings me to what we really are having a lot of discussions about right now is what is the right combination of medications for CKD and type 2 diabetes, or in patients that have type 2 diabetes. Should we be using this pillared approach of 4 medications, or which types of patients might be right for which types of combinations? We've got our backbone pillar number 1, which is RAS blockade, which is going to be the cornerstone no matter what. But we know that SGLT2 inhibitors, finerenone, and GLP-1 RAs all independently showed added benefit in CKD protection when added to RAS blockade. What we don't know is if the other combinations or the combination of all of them are going to give us additive or synergistic effects. But I think that's where a lot of the research will be headed. So I had to mention this since I said this is where the research would be headed. Remember, there were 15% of the FLOW population that were taking SGLT2 inhibitors at baseline. They did do a post-hoc analysis looking at the results in particular with those 15%. It was certainly not powered to detect any difference because it was a small portion of that study. And sure enough, we didn't see any differences between groups in the 15% of people that were taking SGLT2 inhibitors. But I think this just shows that we're definitely going to see more research in this area of combination therapy. So with that, I just wanted to bring it back. So that's the evidence we have in the CKD space. But of course, we're talking about CKM. We're talking about a holistic approach. And our patients don't present with just one problem, but they present with multiple variable problems. So the ADA standards also have some recommendations in terms of drug therapy selection. If you have a patient where you don't want to cause weight gain and you'd actually like to see weight loss, they have a hierarchy of the effectiveness of different categories, with the GLP-1 receptor agonists definitely providing the most weight loss of any of the anti-hyperglycemic agents that we have. In addition, they make some recommendations about hyperglycemia treatment that we really should be selecting treatment options that are going to achieve the target A1Cs that we're shooting for. So again, the GLP-1 receptor agonists really provide the most substantial glucose lowering compared to many of the other anti-hyperglycemics. And both for glucose lowering and for weight loss, the GLP-1 receptor agonists are certainly superior compared to the SGLT2 inhibitors. The KDIGO ADA consensus provides some nice global summaries of comparisons of all of the anti-hyperglycemic options, comparing them in terms of these comorbidities that we're speaking about, cardiovascular disease, heart failure, CKD, but also the impact on glucose, the impact on weight, and then some side effects, such as hypoglycemia risk. And then, of course, on the end is the issue related to cost. So I would say if you're looking specifically at the GLP-1 receptor agonist line, I would say that the first column with the progression of CKD is going to change from a light green to a dark green with the publication of the FLOW trial. But you can see benefit in CKD and cardiovascular disease, high glucose lowering, low hypoglycemia risk, high weight loss, but is certainly expensive medication, which is probably one of the biggest challenges that we have related to access to these medications. And then one thing that is not on that table, but has been included into the ADA algorithm this year is the issue of fatty liver disease. So we know that probably over 70% of people with type 2 diabetes also have fatty liver disease. So the ADA treatment algorithm points this out and says if you need additional treatment at reducing comorbidity risk, or if you have a patient with fatty liver disease, you should be selecting a medication that can be beneficial in that space. And this is a space where the GLP-1 receptor agonists are gaining more clinical evidence at their benefit in this population. I can't be a pharmacist at a kidney meeting without talking about renal drug dosing. It just wouldn't be right for me. So just as a reminder, thinking about the anti-hyperglycemic agents and the limitations that we have to using these agents with different levels of kidney function. Again, the SGLT2 inhibitors can be used all the way down to dialysis now for additional cardiovascular benefit, but they do lose their glucose lowering effect once the eGFR falls below 45. The GLP-1 receptor agonists that we've talked about today can be used at any level of renal dysfunction, so I think that that's a nice benefit for that category. Metformin, we have to remember, is contraindicated when the eGFR falls below 30. DPP-4 inhibitors we're not using very much anymore, but they have some renal dose adjustments that we need to think about, all of them except for linagliptin. Pioglitazone does not have any renal dose adjustment concerns, but we do see some of the adverse effects increase in our CKD patient population, especially if they're on other medications like insulin. And then sulfonylureas and insulin are challenging in chronic kidney disease due to the increased risk of hypoglycemia. Okay, I just want to move on to talk about some of the side effects and how we can potentially mitigate the side effects associated with GLP-1 RAs. The most common side effect, of course, is nausea. We can also see vomiting, diarrhea, constipation, abdominal pain, and dyspepsia. In the diabetes trials looking at GLP-1 RAs, nausea happened in about 1 or 2 out of 10, so 10 to 20% of the patient population, and tended to be mild to moderate in severity and tended to happen in the first 6 weeks or so during initiation and dose titration. The percentage of nausea rates have increased when we use higher doses for weight loss, so you have to keep that in mind, but it's certainly not in 100% of folks. These are all injectable agents except for oral semaglutide, so injection site reaction can be a side effect. It's not something that I see very frequently. And then when using them on their own, they have a low risk of hypoglycemia, but if you're using them in combination with insulin or sulfonylureas, you could see an increased rate of hypoglycemia. So some things to think about to try to mitigate the GI side effects that patients might get when they're taking a GLP-1 RA. We want to think about education, appropriate dose escalation, and then effective management if they do end up getting some of those side effects. So in terms of education, these medications are working to increase satiety and to slow down the gut. And so it's important to tell patients to eat smaller portions and to be really mindful when they're eating. So eat when you're hungry, stop eating when you're feeling full. Eat slowly so you can have some response to those sensations. Avoid lying down after eating. Avoid spicy foods can help as well. If a patient does experience nausea, there are some definite things that you can do. You want to make sure that you're starting at the lowest dose and titrating according to the prescribing information. But you can certainly back off on the dose if somebody's having GI side effects. You can try to titrate more slowly over time. And you could consider trying to switch to a different product if the side effects are intolerable. Some of the guidance that is available now also recommends consideration of short-term use of antiemetics. That's not an option that I particularly want to use, but that is a potential option as well. I think one of the interesting things that we're hearing about now is about the nutritional components of a person's meal when they're on a GLP-1 receptor agonist. So I can mention some of the other safety concerns outside of the GI side effects. There are many, we could talk about them for a while, but most of them are safety concerns that we've worked through and thought about and are as, or the causal relationship hasn't been established. First, we can start with contraindications. So medullary thyroid carcinoma is a contraindication, a black box warning for GLP-1 RAs, and that's because of evidence that we found in rodents. So C-cell carcinomas in rodents has not been found in humans at all, but because of that abundance of caution, it is a black box warning. Luckily, medullary thyroid carcinoma is the least common thyroid cancer, so we don't see it as frequently, but that's the big one from a contraindication perspective. From a precaution standpoint, we've got this long-lasting history with pancreatitis. So we know that pancreatitis rates increase with type 2 diabetes and obesity in and of themselves. So it's not known whether it's just the disease or potentially a link with the medications. But many, many observational studies and then more evaluation with some of the prospective randomized controlled trials have not demonstrated a causal relationship between GLP-1 receptor agonists and pancreatitis. So there is an increase in acute gallbladder disease with GLP-1 RAs. The absolute risk is still very small, but we are seeing an increase in the rates of gallbladder disease. And then retinopathy complications is an interesting one as well. We saw an increase in retinopathy complications in the semaglutide cardiovascular outcome trial. It increased the rates of retinopathy complications from 1.8 out of 100 in placebo to 3 out of 100 in patients taking semaglutide. So still a very small absolute risk, but we did see a risk only in that trial. And most of the cases were in patients that had established retinopathy at baseline. So my practice is if somebody has moderate to severe proliferative retinopathy at baseline, then that's gonna make me pause before I decide to use semaglutide, at least for now, while there are some ongoing trials trying to evaluate that concern in a little bit more detail. Some of the emerging concerns include perioperative and peri-procedure use. So there were some case reports of aspiration in folks that had been on GLP-1 RAs and were going to surgery. So I think there's some new guidance coming out thinking about in high-risk patients, giving them a little bit longer of a time to clean out their gut, a little bit longer of a liquid diet, and in those that are at very high risk, potentially holding the GLP-1 RA before surgery. Of course, we want to balance that between the fact that, of course, we want good glucose control going into surgery so that we can decrease any complications afterwards. Sarcopenia is another concern. Oh yeah, that's right, I was talking about nutritional issues. So I do think it's interesting now that we have GLP-1 receptor agonists that are providing significant amounts of weight loss, the studies were really capturing the reduction in calories that patients were having, but not capturing the nutritional quality of the food that they were eating. So not looking at the macronutrient composition of the food. So I think that there's some concern that if people decrease their caloric intake, but do so with non-nutrient dense foods, that they might have some malnutrition concerns coming down the road. So I think there's going to be some more evidence looking or more research done in that space to try to see what that looks like. And then in the last couple of years, there have been some case reports that have popped out or some things on the internet about suicidal thoughts with GLP-1 RAs. I think there have been several large-scale database trials that have kind of debunked that concern from a population perspective. And then the last emerging concern that I had listed on my slide was just about counterfeit products, misuse, and challenges with access and obtaining the medications. Of course, because of the shortages that we experienced over the last year or two, we started to see a lot of compounded GLP-1s come into play, and now we've seen a lot of med spas, marketing, all sorts of things I just saw one today that was like a GLP-1 boost nutritional supplement product with no information about what might actually be in that powder, and always curious since these are proteins that require subcutaneous administration. So I think that that's a concern for sure, just to think about the safety of what these products or what patients might be searching for on Instagram. We're going to go back to the case vignette with a couple of questions specifically trying to apply all of this information to this case. So just to revisit this case, this was the 54-year-old with an A1C today of 8.1, an ACR of 318, an eGFR of 52. We now know that the cardiovascular, the 10-year risk is around 20 to 25%. And the patient's taking metformin 1,000 milligrams twice daily. We've got, he's relocated recently, has a new job, has got, some medications that he's been out of, has had some not perfect adherence to metformin, maybe because of the side effects he's experiencing. Okay, so with this case, what change to this patient's medication regimen would you recommend next? I feel competitive now with my co-presenter, and I'm only seeing 44 of you that have responded, and I'd like to at least match her number. So pull out your phone if you haven't. Let's try to get these numbers increased. Okay, let's see what we got here. Okay, so no, I'm just kidding. Okay, so I do think that there's a good, clear role for a long-acting GLP-1 receptor agonist, but why? Why is that? I think you could also make the argument somewhat for an SGLT2 inhibitor, for those of you that selected that. You think about what are some of the reasons that maybe some of you selected a GLP-1 RA, and it may be because you're looking at the patient as a whole. You're thinking about that A1C that is still elevated. You're thinking about that person's BMI, and knowing that you want to try to have an impact on both of those, as well as preventing the progression of the person's CKD. So thinking about all of the different layers of that CKM perspective, the GLP-1 receptor agonists certainly tick a lot of those boxes. But I think that there's also a good percentage of you that thought about a combination of more than just one product, and I certainly think that that's where a lot of the discussions are happening. Could we get added benefit with all of those different targets that we're looking at by starting more than one agent? So maybe some of you are thinking about finerenone along with one of these other anti-hyperglycemic options. So not a clear winner for this question by any means. Yeah, and so I think that either of the GLP-1 receptor agonist option is certainly supported by current clinical guidelines. And I think when you think about CKD and the other issues that we're considering at the top, that seems to be a reasonable option. Next question. If you were considering a GLP-1 receptor agonist for our patient, which of the following characteristics would concern you the most? Maybe some of these were a reason why you did not select it in the previous question. Okay, we'll give just a few more seconds here. Okay, so a lot of you selected that history of pancreatitis. Some others had concern for the side effect with metformin, non-adherence with medicines, depression, transition relocation. Okay, so yeah, the history of pancreatitis is an interesting one because I do think it's a kind of a use caution scenario. I don't think that there's necessarily a right or wrong answer here. The evidence that we have as a whole, for me, does not make a causal relationship between GLP-1 receptor agonists and pancreatitis. But certainly if somebody was experiencing an episode of pancreatitis, I would probably discontinue the GLP-1 RA if somebody was on it. For this particular patient, the pancreatitis was many, many years ago and correlated with stopping alcohol use, which could have been related. So I'd probably investigate that a little bit more to find out if that acute pancreatitis episode was related to alcohol consumption. And if the person was no longer drinking alcohol, I personally would feel fine using a GLP-1 RA today. I think the benefits would outweigh the risks for this particular patient. I do think that non-adherence is something that I would consider, and I would find out more about that if he just ran out of meds because he was finding a new provider, or if the non-adherence with the metformin due to the side effect is certainly something to explore, especially because we know that kind of long-term adherence and persistence with GLP-1 RAs can be problematic. So people may start these medications but may not stay on them long-term. So I think that's worth investigating with the patient. And finding out more about those GI side effects, and then really having a good discussion with the patient to try to make sure that if they were to start a GLP-1 RA, that we do so in a way that will be successful from a GI side effect perspective. Okay, yeah, so I think we talked, and you always want to make sure that you start at the lowest dose for these agents and titrate according to the prescribing information to make sure that you're mitigating those side effects. And then last question, if this patient's A1C was less than 7% and his BMI was less than 25%, everything else staying the same, how would that change what your recommendation was previously? There's nothing I like better than a what if question. All right, let's see where we're at. Okay, so I think that's where I was leaning as well. The majority of you who picked an SGLT2 inhibitor, I think that both categories of medications now have evidence at slowing the progression of CKD. I think in the prior case, when you had the additional component of needing to lower glucose quite a bit and needing or wanting to lower weight as well, a GLP-1 RA makes good sense. But if you don't have those other aspects of the patient case, then certainly an SGLT2 inhibitor might be a reasonable option. Okay, with that, we've got some additional readings and resources, and we'd like to open it up to any questions. Thank you so much.
Thank you so much to our speakers. I'm happy to moderate our Q&A here. We've got a few in the app that we're going to start with, and then we also have 2 microphones in the middle of the room if you'd like to ask a question and come up. We've got plenty of time. So first question, everyone's favorite. Do we expect to see further insurance coverage of GLP-1s with the new indications? These are often affordable for my patients. If there's anything you can comment on there.
Well, I wish I had a magic globe up here or magic wand to know the answer to that. I'm not quite sure where things are going to go from an insurance perspective for additional indications. One of the products does have an additional indication for obstructive sleep apnea. I think that's a lot of the angle that we're seeing with some of the clinical trials that are being published, is looking at some of the additional disease state outcomes that are related to overweight and obesity, and trying to get those indications that maybe they think might be better covered. But really, really difficult to know what the coverage situation is going to look like.
So the next question, if glucose level is controlled with the lowest dose of semaglutide, can a person still have the cardiorenal benefits?
I think that's a really great question. The clinical studies tried to force titrate everyone up to the maximum dose, which at the time was 1 milligram, not the 2 milligrams, which is the max dose for diabetes right now. So I think if you're a purist from an evidence-based medicine perspective, you would say the trials titrated everyone up to 1. That's where we saw the benefit. So I'm going to titrate people up to 1. Clinically speaking, though, I don't think we have the answer to that. So I'm not really sure. I think if you're using them for a cardiovascular benefit perspective, I tend to try to increase the dose if they're tolerating it well.
I would just add the cardiologist would probably agree with that in terms of you're looking at the indications, right? And each patient is different. And interestingly, as you're talking about other potential benefits in terms of coverage, started thinking about the antihypertensive medications and the multiple classes we have that have dual benefits. So I think, we could think about when you're putting a patient on a medication, what benefit are you looking for, right? That allows you to choose one over the other or a combination.
That's right, because you're not just using them for weight loss. One of the weight loss trials for the GLP-1 RAs also showed a significant reduction in the transition from prediabetes to diabetes. So it's really treating the CKM earlier in the stages.
So some patients are complaining of sudden hair loss after starting a GLP-1. Is there anything you can comment on there, or if you've seen that?
I've seen some things on the Google, but not anything beyond that. So I don't know if that's just weight loss in general, or whether that's GLP-1 RA specific or nutritional in some way. Yeah.
Thank you so much for such excellent talk. Little bit tweaking to your last question. What if the patient has a hemoglobin A1C of 8, BMI less than 25, already on SGLT2, would you add the GLP-1?
That's a difficult question, but one that I face quite a bit in clinical practice. And I think it really depends on some other considerations. So people hold their BMIs differently. So that's just one thing. But I think if somebody is frail and they, you really don't want them to lose any additional weight, then I will explore other options. But oftentimes I still want to gravitate towards the GLP-1 RA because of the excellent A1C lowering that I get, especially if there's a comorbid condition on top of that where I want to gain the benefits for that population as well. And then I'll be trying to use the lowest dose to try to get the glucose benefit without too much weight loss.
If they have a little bit of microalbuminuria, would it make you lean towards giving the GLP-1?
It would. If they had CKD and they were already on an SGLT2 inhibitor and needed additional glucose lowering, I would definitely want to gravitate towards a GLP-1 RA.
Thank you so much.
Yeah.
So now we're going inpatient now. So what are the recommendations for inpatient care for patients admitted with acute injuries from usage in combination with ARB, ARNI, et cetera? I'm guessing that's GLP-1s in combination.
And they're saying acute kidney injury.
I wonder if it's just related to GLP-1 use, either inpatient or with these weekly, if you have an injection, and so the GLP-1s maybe. Trying to interpret this question a little bit more.
I mean, there have been some case reports of acute kidney injury. So especially if somebody's dehydrated. So if you're on a weekly agent and you're in the hospital for that, then you're not going to give the next dose of the weekly agent. You're going to hold until the person is stable from a fluid perspective and certainly from a kidney perspective.
Yeah.
I agree, yeah. I mean, I think it's a great question. And you start thinking about check boxes. You know, if you could have a list of all the potential complications and side effects of these medications, and then the indications for what you want to use them, you could get closer to understanding and figuring out what the combination would be or what the target therapy would be. But I think we're going to gain a lot more, I guess, ease in terms of administering these meds with more experience.
Next question's on fluid status. So any known impact of the weight loss on fluid status, for example, loss of fluid versus lean body mass? This person's thinking about dialysis, but then also non-dialysis patients.
I think that's a great question, and I think that we need more research in this area of what people are losing when they're losing weight with the GLP-1 RAs. I do think, anecdotally, I have many patients that tell me, like, I just like kind of don't eat as much. I don't think about eating. And for a lot of people, that's life-changing in such a positive way. When you hear them, they're like, I've tried to lose weight my whole life. I've not been successful. And now, I used to, every day was me thinking about my next meal and just being so consumed by that. And the GLP-1 RA allows me to have other things to think about. But in some, you hear patients that say, like, right, I don't feel hungry, so I kind of forget to eat and I forget to drink. So that just kind of decreased desire for consumption, I do think, can lead to not drinking enough fluids, which is why I think when the slides cut out, that slide specifically, we've got a couple of papers in the literature that provide a little bit of guidance in this area of nutrition with GLP-1 RAs that are recommending things like staying really well hydrated. And also, even though you're taking in less calories, you've got to make sure that the calories that you're taking in are of high nutritional value so that you're getting all of the protein that you need and all of the additional things that you need. And I think it's critically important in the CKD population because of those folks that maybe are having a hard time with their nutrition and are going to dialysis or things like that. And you've got to be super cautious about protein and all of those things. So I think we definitely need more evidence and more research in that space.
I would add also, I attended a meeting a few weeks ago, and there was someone mentioned a concern about muscle loss with GLP-1, which I thought, really? I mean, if you're significantly overweight and you have cardiovascular disease, I don't think I'd be worrying about muscle loss because I think it's minimal with GLP-1 RAs anyway. But I think that's something that we need to get out to the public because I was actually pretty, surprised that they were touting significant muscle mass and actually diminishing the use of these medications. So again, I think with experience, we can do a much better job in how we manage, patients appropriately because there's so much benefit from use of these meds.
Go to the floor here.
Hi, my name is Farhan. I'm one of the nephrology fellows. So my question is about the rebound weight gain after the discontinuation of the GLP-1. So what is the physiologic mechanism behind that? And how can we what are the strategies to overcome this side effect?
It's another great question. The literature that I've seen, I think you can say, people on average gain about 70% of the weight back when they stop a clinical trial from a GLP-1 RA. I think it's important to remember that that's an average. So that means that some people were able to keep their weight off and other people gained back all the weight and maybe some additional weight. So I think that those things need to be individualized. Physiologically, I think, these agents really increase satiety and slow down the gut. If you stop taking them, you lose those benefits. And so people will, regain the desire to eat and the gut motility will increase and so you'll lose those benefits. So I think that, when they first were approved for overweight obesity, they were considered to be chronic medications. I think people are definitely investigating how we may be able to do something different. I've heard a lot of people talking about dose titrations down, cycling on and off to see if any of those strategies might work to help people maintain weight once they've lowered it. I haven't seen that evidence yet. I've just heard conversations about trying to do those types of things.
I think one of the things that we really don't pay as much attention to when it comes to weight loss, because I think the approach to using the GLP-1 RAs is like it's a magic pill. I don't have to do anything else. I just take these meds. I don't eat as much, and the weight falls off. But what needs to happen is that you must have nutrition education, exercise, and all of the things that you ordinarily do when it comes to weight management. So when you need to go off of these meds, the weight gain is not going to be as significant because you're already now have changed your diet, much better. So that's the one thing that I have to say that people aren't really focusing as much on, and patients can benefit significantly from that. And maybe that's something that we need to include in our discussions with patients when they are started on these medications.
We have time for one more question in the back there.
As a dietitian and transplant, one thing when I'm working with the diabetics is looking at when they're not eating. I've had people, I'm not eating all day. I'm really concerned sometimes with their blood pressures blood sugars dropping and things.
And sorry, just tell me what your exact question is. I agree that I start worrying too.
I always have been telling, maybe I'm wrong, because when you had the one slide, if they're not hungry, only eat when you're hungry. If you have somebody that's not going to eat for 24 hours, I always try to get them to eat more frequently, smaller, more often things. But that's where it was concerned with the one slide where you said only have meat when they're hungry.
I think that it's it's a challenging discussion to have because people have multiple ways of interpreting those types of discussions, right? And so some folks that may be trying to lose weight or struggling with weight will say, well, you told me I had to eat. And I was like, that's not quite what I meant, or not quite what I said. And so I do think this idea of you need to eat consistently, I think came from the days where everyone was on a sulfonylurea, and you did need to eat consistently to prevent hypoglycemia caused by the drug that we were providing to them. If you don't have them on a medication that causes hypoglycemia, then I don't think we have evidence that supports that people need to eat every so many hours. And I'm not suggesting that it's okay for people to not eat at all for 24 hours, but what I find is that's not always the case when you start digging a little deeper. We all know that 24-hour diet histories, are not very accurate in terms of what they tell us they're eating versus what they may really be eating. But I think this idea of oh no, you have diabetes, it's very important that you eat at consistent times during the day, I don't think is based on any specific evidence. I think it was what we told people when we were putting them on medications that would lead to hypoglycemia if they weren't feeding their treatment.
Dr. Nicholas, any closing thoughts? We're at time.
Well, I would say that, back to CKM, and we have one more question, but back to CKM, this is a fairly new term.
I'm sorry, we're at time, so we do have to, and they'll be available afterwards.
We'll be available.
Really quick.
But just closing remarks. Back to CKM, where this is a new term that we really need to take note of, to be aware of, but also know that there are also still lots of research that needs to be done to answer some of the questions that you all have brought up this afternoon. I hope that this session has been informative for you. Thank you. And we'll be around to take questions.
Thank you so much.
Thank you so much.